is Joe Livoda. He is our CIO at Rural Health Innovations, and I'm going to hand it off to him now.
All right, thank you, Cassie. We're in for a treat today. We have a couple of really great speakers that are going to talk about data analytics, which is a real big topic today in health IT. And in particular, they're going to cover a lot of stuff around big data and using other data sources to come up with some really revealing correlations. Ryan Sandifer and David Mark are both professors at the College of St. Scholastica, and I've had the pleasure of working with them, Ryan in particular, on the REACH program, which was a regional extension center in Minnesota and North Dakota. So with no further ado, I'm going to hand it over to Ryan and David to start their presentation off.
Thank you, Joe, and nice to be able to be on this this webinar. We're excited to be speaking to all of you. As Joe said, my name is Ryan Sandifer. I'm assistant professor and chair at the College of St. Scholastica in Duluth, Minnesota. And David, he's also assistant professor and program director at the College of St. Scholastica. We're both in the Department of Health Informatics and Information Management. So today we're going to be talking to you all about analyzing hospital compare and how you can leverage some data analytics with this publicly available data set to potentially identify some interesting things about your organization or organizations within your area. We're also going to be talking about this in the context of big data and big data in healthcare, some publicly available or free software options that can be used for analytics, and then using all of this as a case study with hospital compare data. So I'm just going to get going on it. So lots of talk about big data in healthcare, big data generally, and there's a lot of definitions about what big data is, about what it's not, about how to use it. But really what we do know in healthcare is that there is a lot of data, and we can start accessing that to really drive outcome improvements. So just to set the context a little bit, one of the cases that can be used to look at the reason or the rationale for using data analytics to drive quality improvement is just by looking at some of these statistics around life expectancy at the age of 40 within males, and what is per capita healthcare spending within OECD countries. And we thought that this would be an interesting example. So if you look at the life expectancy of males in 1976, there's a pretty tight clustering of all OECD countries in terms of cost and life expectancy. But if you look at by year, you can see that life expectancy is increasing across the board, which is good, but you can also see that healthcare spending is rising across the board as well. And you can see the United States starting to separate from that cluster slightly in 1986. If you move to 1996, again, you see life expectancy going up across the board, but you see male life expectancy in the United States not going up as fast, and the per capita spending going up much more rapidly. If you jump forward to 2006, you can see that the United States has significantly separated from the other countries, and male life expectancy is now the lowest. And then if you move up one more to 2011, again here we're almost off of the chart in terms of spending. We're nearly $8,000 per capita spending in healthcare in the United States, and our life expectancy is the lowest. So this is just one example. That's just one example of the issue of quality and cost, and all of the trends are saying we need to utilize data, we need to utilize analytics analytics to try and figure out how to improve quality and decrease costs. One other measure of this is you can just see that costs are spiraling out of control, that the medical costs for a family of 4 in this country have more than doubled in 10 years. So what do we do with all of this? And this list can go on and on and on, right? We can show that drugs seem to only work in 30 to 60% of the people that they are administered to, that $250 to $325 billion is spent annually on unwarranted care, that like I said earlier, there are almost 8,000 per person for per capita spending on health care, and that if we don't act soon, 20% of our economy, or more than $4 trillion, was spent on health care. That's very problematic, especially when you consider that estimates say that if we hit 22% of GDP, that would bankrupt the country. So, just to tee this up, we are either headed towards restrictive rationing, or that our healthcare systems will be unable to consume or deliver medical innovation because it's too expensive, or perhaps there's an option where there's an option for real change by using outcomes data to drive care. And that's where data analytics comes in from our perspective. There's a lot of opportunity for secondary use of healthcare data in this country. It's just, the data is not historically been seen as an asset to be used to drive business. But there's a lot of different ways to use it. I mean, we can use it for to work with healthcare providers to really improve on clinical quality initiatives and reporting. We know that there's operational efficiencies that can be gained by leveraging our data as an asset. Financial management, as we've just been talking about, is extremely important. And we know that pay for performance is a reality now. And that's a reality that's cutting across almost all sectors of the healthcare continuum. Obviously, there's comparative effectiveness research that is being conducted that is able to take advantage of this data and analytics. We know that personalized medicine and patient empowerment and patient engagement is an area that's of increasing importance in terms of driving quality and reducing costs. We know that academic medical centers, that there's a lot of different research that's being done there, but that research is being done is flowing down across the healthcare continuum. And then obviously when we're talking about all of these things that are being done on the within different populations and groups of patients and providers and practices and settings, that needs to be done on a much larger scale in terms of population and public health. So we know that there's a lot of opportunity for the use of secondary analysis of data. Obviously, evidence-based medicine is driving that. We know that we can develop best practices, both at the smaller and local level, as well as the population level. We know that this can drive empowerment, both in terms of best practices among organizations and with patients. We know that there's a lot of preventative work that can be done that analytics can assist with. That's both in terms of organization-created data, but also patient-generated data, and how those two are beginning to intersect. We're hoping to lower cost, obviously, because we talked about the issues in terms of more resources being constrained. Predictive analytics is obviously increasingly important. How do we predict readmissions earlier to be able to prevent them? And then obviously we're getting down to the personalized medicine in terms of doing genome-wide associated studies, also known as GWAS. And just we wanted to make sure we clarified that not to confuse GWAS in terms of genome-wide associated studies with the more commonly known GWAS, which is the Great Western Alpaca Show. That is something really important not to confuse. And again, big data, it's a big deal. It's a huge topic. If you Google big data currently, you get over 781 million hits. And that's why to be able to harness big data, you have to have resources to be able to use it. healthcare, big data is also a big deal. And just to illustrate how big of a deal it is, so in 2012, it was estimated that there were 500 petabytes of healthcare data globally. And that's the equivalent of 10 billion four-drawer cabinets for those of you who have recently converted from paper to electronic. If you think about what this is going to look like in less than 8 years, 2020, from 2012 that is, we're going to see the global scale of healthcare data grow over 50 times, from 10 billion four-drawer cabinets to 500 billion four-drawer cabinets of healthcare data. So, I mean, just thinking about that, it's incredible in terms of how much information that we're collecting. But what's more incredible is that we're not utilizing that data as effectively as we can. So we have the data. The question is now, what do we do with it, and how do we do those things with it once we have it? And David, I'm going to kick it over to you now.
Thank you, Ryan. So the question is, we have all this data, now what? And part of that answer could be, we need to think about data analytics. How can we utilize different methods and procedures for analyzing this data to make more informed decisions for the patient, for the provider, for the healthcare organization, and also thinking more in terms of population health. And where it needs to start is we need to consider, we as whether we're practitioners or we're in a role as a data analyst, or if we're administrators, we need to think of how we're going to get to the point of having all this data to information, and how we're going to implement data analytics. Where it starts is it really starts with training. Data analytics does require training. You need to know how to work with large data sets to implement different analytical procedures to make those informed decisions. And it's analogous to running a marathon. And given that, actually, this week, actually, the Grandma's Marathon will be happening in Duluth, Minnesota. And it's a big deal. And you can clearly see in those running Grandma's Marathon who has trained and who has not. And an example is shown on the screen here. So I'm shown on the right side of the screen, and this is during the Gary of Bjorkland Half Marathon, and this is at mile 11. You see, I'm happy. I'm ready to go, ready for that finish line. I did train for the Grandma's Half Marathon. Then Ryan, shown on the left side of the screen, well, Ryan didn't train, and you can clearly see the pain that Ryan is going through due to the fact that he did not train. And that can be analogous to analytics. Without training, it really is painful. So where do we start? What do we do? Well, first we have to consider what are our options for software? What tools can we use to implement data analytics? There are a lot of options out there. There's freely available resources as well as licensed resources. And how can we filter through all these resources and tools that are available to really use something and adopt something that's going to work for your organization? Let's cover licensed software first. There are a lot of options. You could consider looking at SPSS, which is a data analytics platform that's really applicable for psychological research. That's how it was designed. It's for that field. But it is being used by many healthcare organizations. It's a point-and-click interface that really helps to facilitate more of a statistical analysis using inferential statistics of your data. However, it tends to be a little slow at times when you get to very large data sets. PRISM is widely used in biological research and also used in laboratory medicine. And it's used to, it has built into it the various modules that are necessary for reporting out to the regulatory agencies for labs, such as CLIA, for instance. But it does have its limits, similar to SPSS, when you use large data sets, in that it can get relatively bogged down. Excel, and I'm sure at least some of you have heard of this thing called Microsoft Excel. And I'm joking. Excel is probably the most widely used analytics platform for health data analytics. Excel is a great tool for summarizing data, but it can have its limitations, again, when you get to very large data sets. In that Excel is only limited to, at least the more recent version, to 1 million rows of data. Once you get beyond those 1 million rows of data, you can't use Excel in its native form. Also, when you're dealing with a lot of formulas, Excel can bog down quite a bit. SAS is a widely adopted analytics platform that is very powerful and versatile and can handle very large data sets. It can be, you can hook it up to your database or your data warehouse, and you can do a variety of different analytical procedures and also data visualization. It's also a very expensive option, so it can be cost prohibitive for some organizations, particularly those rural hospitals, to adopt a platform like SAS given the price point. This is where free software and open source tools are an option that healthcare organizations should really consider. 9 is one software that organizations could consider looking at. It's really meant to facilitate data mining. And it is a free tool. It has a nice intuitive design to it, a point-and-click interface. It's easy to get going and using 9. But there is somewhat of a learning curve of how to actually do data mining. You have to know what's the data mining process and what are these different algorithms that are being used in the software. So there is a learning curve related to that. Weka is another software option. This is a free data mining tool. It tends to involve a more of a steeper learning curve, as the interface isn't very intuitive, but it is another very powerful free software tool. R is a very powerful tool that doesn't just do data mining. It can do basic descriptive statistics. You could do a variety of different data visualizations. You can do inferential statistics. It also does data mining. You can transform your data into different organizations. It can hook up to your data warehouse. It does offer a lot of options for healthcare organizations, as not only because it's a very, very powerful tool, but also the fact that it's free is something that healthcare organizations should really be looking at for advancing the analytics that they could be doing and promoting with their data. So R is a software option that is widely available and widely used in other sectors outside of healthcare. In fact, there's research to show that R is one of the fastest growing data analytics platforms in the world. But when we consider our software, we need to consider what it should do for us. And really, you should choose software that meets your needs. So you might need it to do things such as basic data manipulation, where you have to read decode data. You have to transform that data into a different sort of format. You might need it to do some various statistics, whether that's calculating averages or the median or calculating percentages. These various descriptive statistics are probably the most common method of analyzing the healthcare data and getting an idea of the trends over time. So, of course, your platform should be able to do that. But you could also consider hypothesis testing. This is where we're using inferential statistics like t-tests, ANOVAs, linear regressions, and trying to find if there are significant differences or significant associations in your data using statistical methods. Data mining is another approach. Can you use descriptive and predictive data mining techniques to be able to use your historical data to then inform you how you could drive decisions on more prospective data, data that you're actively collecting. And also data visualization. Being able to visualize data in a succinct manner that is easy to interpret is essential because you're ultimately analyzing the data to inform some audience. If that audience are physicians or if that audience are administrators, you need to consider what are the methods of visualizing that data that I need to adopt to present that information effectively. And speaking about data visualization, there are a lot of enterprise data warehousing tools that are really growing, and the number of these tools is growing as well. Some of those, the more popular ones include the following. QlikView is really growing in popularity. It's an enterprise data warehousing tool that has built into it really nice data visualizations, and it provides a nice platform to be able to get a sense of performance data, of clinical data, and it can be used across the organization. Health Catalyst is another product that is built on top of QlikView, and it actually, what that organization offers is training to accompany their platform. Splunk looks at log files and is a nice platform that could be used for looking at intrusion detection. SAS Enterprise is a tool that's built into the SAS suite that could be used for the data visualization as well as hooking it up to your data warehouse. SAP is another option. There are many, many options when it comes to enterprise data warehousing. And again, there are these different platforms really have, they are suitable for different organizations. And so it's really a matter of figuring out what do you as an organization, what are the things you need your data analytics platform to do, from basic descriptive statistics to the data visualizations. What is it going to look like? What should it look like? You also need to consider what can you do with your data. So you might have a variety of different data sets available to you, whether it's the clinical data or data that's reported back to you from payers. You need to consider what is this data and what can you do with this data. And where to start is you could consider, well, what questions could I develop with the data that I have available to me? So, for instance, if it's clinical data, you might be able to look at this clinical data and be able to determine if there's a particular age group that has a more of an aberrant values with their clinical data. You could use that data then to make informed decisions about what are the areas of health or wellness that I should be promoting at my organization. There are a variety of different questions. If you could be looking at claims data and developing questions about what is the typical patient population that you're seeing? Where are the majority of my claims coming from? What are my top diagnoses? These are questions that you can ask, and using analytical procedures, be able to make informed decisions using these various analytical tools. You also need to prepare your data for analysis. This is the most timely, the most time-intensive, as well as the most important step in the data analytics process. You need to ensure that the data is in a format that's really going to allow you to analyze it to make these informed decisions. And when looking at your data and considering how you're going to summarize it and how you're going to prepare it, you need to begin by getting an understanding of the types of data you're working with. There's two main types of data. There's quantitative data and there's qualitative data. Quantitative data is data that has a numeric value to it. And underneath that, there is two different types of quantitative data, interval and ratio. Interval data are data that have, where a value of 0 has meaning. For instance, zero temperature, that is interpreted as a meaningful value if there's 0 degrees Fahrenheit. A ratio data is data that is what we most commonly see in quantitative data. For instance, you might have age or length of stay. Those values could are quantitative data, and a value of 0 really is interpreted as the lack of. It is a length of stay of 0 is the lack of a length of stay. They're only there for 0 days. Then you have qualitative data. This is categorical data. Data you can put into groups. There's two real types of qualitative data. One is nominal, and the other is ordinal. Nominal data are data that don't have any apparent order to them, and it could be any sort of group. So for instance, gender, males and females, that's a nominal type of data. Eye color is another example of a nominal data. There's no real order to it. However, ordinal data is groups of data, qualitative categories that have a natural order. An example, age groups. You have an age group, let's say, from 0 to 5-year-olds, from 6 to 11-year-olds, 12 to 16-year-olds. These age groups have an order from the youngest to the oldest. Another example would be patient satisfaction survey data. Any sort of survey data, there's typically an order to that qualitative data, where it could be from, if the answer to the surveys would be on a scale of from strongly disagree to strongly agree, there's an order from going from strongly disagree to strongly agree. So why is it important to understand the type of data you're working with? It's important because that's going to influence the type of analysis you do on that data. For example, if you're working with data that is gender, gender could be coded in a variety of different ways. It could be coded as the words male and female. It could also be coded as M and S. However, commonly, data such as gender is coded in a numeric form, such as 1s and 2s. So when you're considering that type of data, and if it's formatted in a numeric type of summary, the data, even though it's stored as a number, it still is qualitative data, meaning that if you were to take an average of the gender, because it's stored as 1s and 2s, you could actually calculate an average. But average gender really doesn't make any sense. So rather than using more of these quantitative approaches to summarizing your data, you need to consider a different approach for summarizing the qualitative data. An example of a different approach would be, rather than calculating an average, you can look at the frequency that each gender occurs, or what is the percentage of males and percentage of females. Another example would be if you had data looking at the different EHR systems. You could have it as more of a textual description or as a numeric description. And if you took an average, if you stored it in a numeric format, if you took an average of the EHR system, that wouldn't make any sense. So this is why it's important to understand, here is the data that I have. Here's the format it's stored in, and that's really going to inform me on the type of analysis I can perform on that data. You also, in that data preparation phase, need to consider the bad data. Very often, we have these erroneous values that are built into our data set. You need to make sure that you remove that bad data. Oftentimes, these erroneous values will be stored as text. So, for instance, it could be stored as the word not available. Oftentimes, it's abbreviated just as NA. Sometimes in the data that's reported back to you, for instance, if you look at some of the hospital compared data, oftentimes for these rural hospitals, you see that it's reported as cases too small, where there's just not enough data to report for that organization. Other times, if you're getting data from a database, sometimes the null values are stored as a numeric value. So, for instance, if it's null or there isn't anything entered, it is actually stored as negative 9999.99, and there's oftentimes different numerical ways of storing something as a null or erroneous value. So consequently, if you kept that negative 9999.99 in your data, and you were to actually conduct an analysis, that could really skew your results. So it's best to remove these erroneous values before you get to an analysis. After you've prepared your data and cleaned up your data, you're ready to conduct an analysis. And there's a variety of techniques you can use when you're carrying out that analysis. One way is descriptive statistics. So oftentimes when we're talking about descriptive statistics, we're really referring to four main measures: shape, center, spread, and outliers. The shape is what are the typical values? So for instance, how symmetric is my data? So if you were to present the data on a histogram, what does the distribution look like? Does it follow that normal distribution of a bell-shaped curve, or is your data skewed? If it is skewed, you have to consider how is that going to influence further analysis, which brings us to the next type of descriptive statistic, is the center of your data. That is, what is the typical value? What is the mean? What is the median? Also, you can think about how can the shape influence the center of my data. So if you have positively skewed data where the data has a tail to the right of the distribution, if you were to calculate an average, the average may not be the best indicator of the center of your data, because these higher values could be skewing your average upward. Instead, a median might be a better depiction of the typical value. Therefore, by considering the shape, that's going to inform you about what is the best measure to look at the center of your data. Brings us to the next one, the spread. How spread out is your data? And there's a variety of ways to look at that. You could look at the standard deviation. You could look at interquartile range. You could also look at your minimum and maximum values. That is, what is the variance in my data? How spread out is it? When I look at the average, and I look at one standard deviation above and below that average, how far apart are those values at the one standard deviation from my center? And that's going to give you a better idea of what percentage of your patient population falls within certain ranges. And then there's outliers. Outliers are data that don't belong in your data set. Identifying outliers is a tricky process. You could use some of the adopted methodologies, such as there's one called IQR times 1.5, where you take the interquartile range of your data, you multiply that times 1.5, and then you add that to your third quartile and then to your first quartile. Seems complicated, right? And really, these methods of identifying outliers, these statistical ways of identifying outliers, they're not perfect. There's flaws in those methods. And why that is because it's really up to the investigator, the person asking the question and doing the analysis, to determine what an outlier is. And here's an example. If you're looking at data that is of age, so let's say you look at age and you find that overall you have a nice normal distribution, but then there's a few outliers on the upper end of that age. You can have some individuals that are 105 years old or 108 years old, and you're saying to yourself, you're asking to yourself, is this an outlier? Are these older individuals, are they an outliers? Well, maybe, and maybe not. It depends on what you're doing. If you want to get a sense of what is the what does your overall patient population look like, you might want to include them in your analysis, as you do have some patients that have that are in this higher age range. However, if you're asking a question such as what is the typical blood glucose level in my patients with diabetes, by including the higher age range, you may actually skew some results. Or if you're looking at what is the average length of stay for patients in my ICUs, by including the higher age ranges, you may actually be skewing the data. And you may think of, well, I have these potential outliers. Could I segregate my data in such a way that I could see how these outliers may be influencing my overall data? So for instance, looking at a younger age range and seeing what the average length of stay is, we're looking at an older age range and seeing what the average length of stay is. Identifying outliers is a very subjective process. It's up to the individual that's really doing the analysis to determine what if something is an outlier or not. There's a variety of different types of analyses as well. You could talk, we've already mentioned the statistical analysis, where you could administer these inferential statistical methods such as t-tests, linear regressions, ANOVAs. You can also think of non-parametric tests. There's a variety of different procedures you could use. And when it's appropriate to use these is when you have a specific question and hypothesis that you want to determine if there's a significant difference between groups. And this could be important when you're trying to report out statistics such as, does my organization have a significantly different observed outcomes than other organizations? And we're going to provide an example of that in the upcoming slides. There's also data mining. And we have to think of data mining not just as this obscure thing, but there's actually methods that go along with data mining. There's terms such as neural networks, decision trees, k-means clustering, random forests, these association rule mining. There's a variety of different procedures and algorithms that actually are data mining methods. And when we talk about data mining, I don't think we oftentimes think about these methods. We think about it as more of an obscure thing where we're actually chiseling away at the data to find these trends. But there are methods that can be used for predictive analytics and descriptive analytics to apply to your data to then actually use these artificial intelligence to then apply a data mining algorithm for things such as decision support. This is where data mining is being used. And we have to have a better understanding of what data mining is and if it's an appropriate thing to adopt for our organization. Next, you need to consider, how am I going to summarize my findings? And this is really where you need to consider the different visualization methods. What methods could I use to present the data to my audience to get some, to ensure that my audience is able to interpret the findings and also to be able to see if there's changes over time if you're trying to trend out your findings over time. So there's a variety of different tables and charts and graphs that you could use. There's bar plots, line plots, pie charts, there's radar plots, scatter plots, spark lines. I mean, you name it. There's a variety of different ways. This is where these enterprise data warehousing tools have really capitalized their understanding of health data to be able to present it in a way that is really maximizes this interpretation to its intended audience. Also, the reports that could be generated. If you are doing an analysis on your data, that needs to be done frequently on, let's say, an annual basis, or if it's done on a quarterly basis. By generating a report, this could allow you to interpret and present the data not only with a graphical depiction, but with tables, and then also a textual summary of what the data is showing you, so that this is something you could put in front of someone, they know exactly what you're trying to say. And then lastly, you have to consider how, when I disseminate these findings, who am I disseminating them to, and how often am I going to do that? So will you reuse your method of analysis in the future? And if so, how are you going to reuse it? Consider, were there gaps in your analysis? And if so, if you are going to redo the analysis, how am I going to address those gaps? Also consider the ways of improving your analysis. Is there additional data you should bring in to enrich that analysis? And also, could I apply a similar method to an entirely different data set? These are things you should consider once you've finished that analytical process. So I'd like to now provide you an example of an analysis. This is where we've actually used some public data and leverage the use of this public data for organizational decisions. So the question that we developed using data, that was actually the data that we used was available through Hospital Compare. And this is freely available data that is published through the Hospital Compare web portal. And it's freely available and downloadable. So I encourage you to take a look at it. And you can look at the Hospital Compare data has data on readmission rates. It has some performance data, and it also has some the patient satisfaction data. So it is a really rich data set. So the question that we wanted to ask was, looking at this data, could we determine if a specific organization has a significantly different 30-day readmission rate for heart failure when compared to the state average? And being that we are located in Duluth, Minnesota, we felt it was reasonable to look at one of the larger healthcare organizations in our area, Essentia Health St. Mary's. So we looked at data from Essentia Health St. Mary's to see if their 30-day readmission rate for heart failure is different than the Minnesota state average. So we obtained the data from Hospital Compare, and the link is shown on the screen here. And what's nice about this web portal is that it has built into it some filtering options. So you can filter the data that you want to export based on your location or based on the performance measure you want to include. And that's shown on the screen here. You can see that on the right side of the screen, you have the filtering options. And the state that is being filtered is Minnesota, and the measure name is heart failure 30-day readmission. The first thing we had to do is once we exported that data is we needed to remove erroneous values. So we exported data for every hospital in Minnesota that had data available. And some of the hospitals do not have data available. This is largely because there weren't enough cases to report on heart failure readmission. So, or they just didn't meet the reporting period, and they didn't have data available. So this is where we removed the erroneous values. And what we had to remove is any text that in the cells that was read not available. So we removed not available with just a blank entry. The way we did this is using Microsoft Excel. So you can use the Find and Replace tool to remove these erroneous values. Once that was done, we were able to run some basic descriptive statistics just in Excel. So we found that the heart failure 30-day readmission rate for Essentia was 21.5. And if you look at the Minnesota state average, and there was a total of 87 hospitals included in that average, it included the state average was for the 30-day readmission rate was 22.2. So Essentia does have a slightly lower 30-day readmission rate than the Minnesota state average. And you can also compare that to the national average of 22.7. So you could, if you wanted to, you could compare Essentia Health to the national average. When you draw this out and consider the descriptive statistics and the distribution of that data, that is looking at the shape of the data, the spread of the data, and also the center of the data, you can generate a histogram to do much of that for you. The histogram you see on the x-axis, or the bottom axis here, is all the heart failure readmission rates. And this is data for hospitals in Minnesota. So you can see that first bar of that histogram is 18 to 19. So if the readmission rate, a 30-day readmission rate was between 18 and 19, there were about 2 hospitals with a readmission rate between 18 and 19. If you look from 19 to 20, also again around 2 hospitals. From 20 to 21, there were about 7 hospitals. You can see that most hospitals had a rate between 21 and 22. So if you look at the blue line on the graph here, this is actually the Minnesota state average. So if you recall from our prior slide, the Minnesota state average is 22.2, and that's shown as the blue line. Now, the red line is the observed readmission rate for Essentia, and if you recall, that was 21.5. So you can see that the Essentia observed readmission rate is close to the readmission rate for the Minnesota state average. But given that that's close, is the difference still significant? The a readmission rate greater than Essentia, as well as there's a fair number of hospitals that have a readmission rate that falls within this center of our distribution. And overall, how does Essentia Health fit relative to the rest of the hospitals in Minnesota? So statistically, to answer that question, you can conduct a statistical procedure, and we use a one-sample t-test. So using the R statistical software package, we used a one-sample t-test to answer that question. What we found is we get a p-value from that statistical procedure, which tells us that, in fact, our observed readmission rate for Essentia Health, which again was 21.5, was significantly different than the Minnesota state average of 22.2. So, yes, in fact, that difference was significant. And you could then think of, well, how can I visualize this difference to really see what its impact is over time? So overall, what we concluded from that statistical procedure is that the 30-day heart failure readmission rate for Essentia Health, which is 21.6, is significantly lower than the Minnesota state average of 22.2. We can visualize this with a bar plot and show that Essentia Health does, in fact, have a lower value than Minnesota. But maybe a better way to present it is showing it on like this dot plot. So it's a little difficult to see here, but if you count, I think it was 7 hospitals. So what's shown here is this. On the, what's listed in the text going on the y-axis there are all the names of the hospitals that were included in this, that had 30-day heart failure readmission rates reported. Shown at the bottom is Mercy Hospital in Coon Rapids. And if you count like 7 hospitals up, maybe it's a little more than that, that's where Essentia Health falls. So you can then clearly see that Essentia Health is towards more of the bottom portion of the overall number of hospitals that are in the state of Minnesota. So this could be a very effective way showing up how your organization lines up to the rest of the organization in the state of Minnesota or in wherever you're located. Also, considering what the state is showing, you could offer a brief write-up of the data sources and analysis and findings, create some tables and figures to accompany the write-up, and then also decide how often this analysis needs to be conducted. Given that this data is reported on a quarterly basis, you might want to see if there's this different changes over the period or across each quarter. So why this is important is that you could use these benchmarking procedures and using public data to really assess the performance of an organization compared to other organizations or compared to the state average. And there were, in fact, 17 hospitals that did have a lower readmission rate than Essentia Health in this analysis, and 69 Minnesota hospitals intervention was doing pretty well. So how can you use the same data, and how can you do something similar? Well, you could examine how your organization or a group of organizations perform across various outcome measures. You could look at readmission, mortality, healthcare-associated infections, and you could compare your organization against regional, state, and national averages, and also trend that data over time. So overall, we have reached this era of big data. We need to think of how can we leverage this data through analytics. The profession of looking at health information, there's really a greater emphasis around data analytics. We need to think about how we can incorporate data analytics across an organization. Even though it could be a challenge, there are so many opportunities with this data. There's also freely available tools and data that you can use to help begin this process. And I'd like to end by sharing a quote by Lee Holtz, who is a former college football coach and newscaster. And Lee Holtz said, "Ability is what you're capable of doing. Motivation determines what you do. And the attitude determines how well you do it." And I think that's really a good way of approaching analytics. Although it could be a challenge, we need to be motivated to do it. We need to really shift our attitude to looking at this as an opportunity. And we need to consider, what do we need to do to get analytics, to use analytics, learn about analytics, and really move that, allow analytics to move our organization forward. So thank you. At this time, we welcome any questions.
Thank you, David and Ryan. That was very interesting. My mind was spinning on some things there. If you'd like to ask a question, I please encourage you to do so. And if you look, you can type a question in the chat box is one way to do it. Otherwise, you can unmute your line with *2 and go ahead and ask away. Anybody have a question right off the bat? I know I have one. David, you covered using hospital compare and some of that publicly available data. Do you have any other examples that you could talk about for using publicly available data to compare yourself to your peers?
Sure. There's, when we talk about population health, and that's kind of a growing area, there's a lot of public data that we could consider using for more of a population health analysis. One data set in particular is the Community Health Status Indicator data that is the CDC, I believe, publishes that. And that's a freely available data source. So I do encourage people to look at that data source. There's also, I encourage people to look at healthdata.gov, which has a lot of data for regional data, so that organizations could look at even data from their local Department of Health